Hello there, my name is Tim Lane, fourth year medical student at Loyola University Chicago, Stritch School of Medicine. And with today's podcast, I'm going to be talking about the basics of ocular ultrasound within the emergency department and take a closer peek into associated ocular pathology. Brief overview of what we'll talk about today. We'll talk about uses of the ultrasound for ocular pathology. I'll introduce a brief case that was actually seen in the ED over my month here on the ultrasound rotation. We'll talk about the ultrasound equipment and techniques, and then we'll discuss some pathology such as retinal detachment, posterior vitreous detachment, vitreous hemorrhage, the use of ultrasound in evaluating intracranial pressure, and then we'll talk about some conclusions and take-home point. A study was done in 2002, bedside ultrasound for ocular pathologies in the emergency department to kind of look into the ability of emergency medicine doctors to diagnose ocular pathology. It showed a sensitivity of 100%, specificity of 97.2%, and some actually really good positive and negative predictive values. Now this is also dependent on the user of the ultrasound. And they took into account people who had done at least over 150 ultrasounds within the department as being non-beginners, and this is the outcome that it showed. So it is a useful tool to use for ocular pathology in the ED. Some indications for ocular ultrasound include, as we discussed before, briefly retinal detachment, vitreous hemorrhage, vitreous detachment, use of it to identify any foreign bodies that may be embedded in the globe of the eye, lens dislocation, retrobulbar hematoma, optic nerve sheath diameter, intracranial pressure, as well as light reflex, a pupillary light reflex. If a patient comes in and you can't, for some reason they had trauma to their face, and you can't identify or open their eye to be able to do a pupillary exam, you can actually use the ultrasound machine to visualize the pupil on the ultrasound screen and shine light into either an unaffected eye or even just on the outside of the unaffected eye in order to see a pupillary response of pupillary constriction. So that's kind of a neat alternative that you can use to really evaluate for reflex of the pupil. There are some contraindications, however, to using ultrasound. Obvious or suspected globe rupture is a situation where you wouldn't want to put a probe onto a patient's eye, as well as significant periorbital injuries. I know we discussed the pupillary reflex just previous to this, but you have to kind of use your judgment to say, okay, I don't want to injure this person's orbital area any more than it already is, and you got to kind of use your judgment to make sure that it's going to be beneficial rather than harmful. Also, if they're suspected clinically significant retrobulbar hematoma, it can sometimes be a contraindication to using ultrasound to evaluate the eye. So kind of a brief case discussion here. I'll introduce this 68-year-old female. She came into the ED with complaint of blurry vision and seeing floaters and flashes of light in her left eye for the last 4 hours. She denied any pain, any loss of vision, no headache or dizziness, and she denied any trauma to the affected eye. She does have a history of cataracts, status post-surgical repair in both eyes, and myopia with corrective lenses. So first things first, with this history, you're concerned about, obviously, an ocular pathology. You're wondering about a differential diagnosis that could include retinal detachment, vitreous detachment, vitreous hemorrhage. She doesn't report any vision loss, so you're less worried about maybe a retinal artery occlusion, but you're probably going to call ophtho. But waiting for them to come down, you can do some things in the meantime, and ultrasound is a great way to really evaluate the eye to see what may be going on. So first things, what probe do you use? Really the best probe to use is the one that will show you the most detail. It'll give you the best resolution, which is the linear array probe, and it's got high frequency, so those sound waves don't travel very far, and you can see at very high resolution of these superficial structures. One trick that you can use is to place a tegaderm over the affected eye and have the patient close their eyelid, and this will ensure that the patient doesn't open their eyelid while you're doing the scan, and also allows the gel to really just kind of coat the entire orbital area without having to really worry about any gel possibly getting into the eye. One thing you want to make sure you do is get all the air bubbles out of the underneath the tegaderm once you place it, for this could kind of obscure your picture as you're doing your scan. You want to brace your hand kind of over the patient's forehead, and with your kind of off fingers, or the fingers you're not using to really manipulate the probe. You can brace your hand against the patient's nose, kind of the bridge of their nose and their eyebrow, and make sure you use a decent amount of gel over that eye in order to get the best picture that you can. The technique is to always image in 2 planes. So you want to start with the transverse plane in order to get a good view of the entire globe, and then change to sagittal or longitudinal plane in order to get another view, in order to basically compare the two and make sure there's no irregularities noticed within the globe in both of those planes. Again, use a decent amount of gel so it's easy to rotate the probe and manipulate it over the patient's eye. It's also better to have the patient move their eye when you have a good view in both planes. Have them move the eye back and forth and up and down in order to get really the full picture of the entire globe and the movements. It's just a brief overview of some anatomy of what you're going to see with the ultrasound machine. You will be able to see the cornea. The pupil and iris are seen kind of as some really thin hyperechoic structures. The lens will also be visualized kind of within the anterior chamber here, as well as the posterior chamber of the retina and the optic nerve. We'll go into some pictures of what the actual ultrasound will look like in a moment. So again, you have your anterior segment, which includes your cornea, the aqueous humor, the iris, and the lens, and then your posterior segment, which has the vitreous body, the retina, the sclera, and then the optic nerve is posterior to that. So here's a picture of the actual ultrasound of the eye. As you can see, the top arrow is showing and pointing to the cornea. You can see kind of a nice thin hyperechoic structure at the top, followed by a hypoechoic region before you get to the iris and the pupil. The lens is posterior to that, which is going to have, which is indicated here by the second arrow in the middle, and then deeper than that on the ultrasound image, you'll see the third arrow is pointing to the retina, and you're kind of looking for the contour, the shape of the entire globe. Make sure there's no irregularities within the retina, and anything that may be floating or within the vitreous body. So this is showing just kind of in better detail what you're actually doing with the probe. Keep your probe against the globe of the eye with a copious amount of gel. Use your fingers for nasal support, and you're viewing the anterior chamber, the vitreous, the retina. And then the optic nerve is going to show up as kind of a hypoechoic type region to the posterior of the eye, which will be furthest down on the screen, the ultrasound screen, and you can tell it's kind of it looks like a sheath. It's darker than the surrounding tissue, and you can really evaluate the diameter of that optic nerve, and we'll get into that, the usefulness of that, in a little while. So first thing I want to talk about is retinal detachment, or really can be on your differential when you have acute non-traumatic vision loss. The risk factors for retinal detachment are increased age, myopia, cataract surgery, diabetes, sickle cell disease, and of course there's two articles I looked at, one from 2011 and another one from 2014, that looked at the diagnostic ability of ultrasound for retinal detachment, and it showed actually a pretty high sensitivity, 97% for ED physicians using bedside ultrasound to diagnose or at least evaluate retinal detachment, as well as 97% specificity on 92 examinations done within the ED. There was a meta-analysis done in 2014 of bedside ultrasound in the ED to diagnose retinal detachment, and it also showed a high sensitivity and specificity for ED physicians to be able to diagnose retinal detachment with ultrasound. So what are you looking for on ultrasound when you suspect there may be a retinal detachment? Here on the left side of the screen, you can tell that there's you can see the globe of the eye here, kind of in the middle. The cornea and iris and lens are to the upper left-hand corner, and the posterior of the eye, there seems to be this extra flap that's kind of an irregular contour of that retina. It's nice that they show this picture here on the right that you can tell the actual contour of that retina has been detached from the normal kind of oval curvature of what the retina should look like. This is what you would see if you're suspecting retinal detachment, and can be used to diagnose it when you are noticing this irregularity along the posterior segment of the eye. Now this would go along with really floaters, seeing flashes of light in one eye, or painless vision loss that patients report and come in. You want to ultrasound these individuals to make sure that the retinal detachment is not what is going on. But this is what you would see if that retinal detachment were present. Next, I'll talk about vitreous hemorrhage, again from non-traumatic form of vision loss. Really, this is bleeding from vessels in the vitreous space. Risk factors include diabetes, trauma, and retinal tears. When the retina tears, there are many microvessels that can bleed and cause this vitreous hemorrhage. Symptoms include floaters, flashes of light, cloudy vision, blurry vision. Patients typically in the unilateral eye, but sure can present as bilateral. Most often, though, you will see unilateral symptoms and patients presenting this way. So again, looking at the technique using the linear probe for vitreous detachment and vitreous hemorrhage, really you want to look at the posterior chamber, the vitreous body, and the retina. This is showing a vitreous hemorrhage in the bottom picture. You can tell that there's some kind of floating material, it almost seems like, in the posterior segment of the eye. Sometimes with the vitreous hemorrhage, you'll see kind of considerable amount of cloudiness to the posterior segment of the eye. We'll go over the vitreous detachment in a minute here, but really you're looking at that posterior segment to make sure that there's no material or tissue that has detached from the back portion of the eye. So this is a posterior vitreous detachment. As you can see from the video, the patient moves his or her eye back and forth, and you can see this linear structure that's a little bit hyperechoic, that's kind of flipping and floating in the posterior chamber of her eye. This is actually video of the patient's ultrasound of the case that we discussed earlier, and this is indicative of the posterior vitreous detachment. The most common cause of flashes and floaters is actually the posterior vitreous detachment, and is found in about 75% of those aged 65 and older. Risk factors for developing a posterior vitreous detachment are increasing age, myopia, intraocular surgery, and of course eye trauma. Another thing that you can do is evaluate intracranial pressure with the optic nerve sheath. So as we showed before, you can really view that optic nerve in the posterior segment of the eye, and really you want to look at the diameter of that optic nerve sheath. It's an extension of the dura mater. It communicates directly with the brain and really is an indicator of increased intracranial pressure. If that diameter exceeds 5 millimeters, you're wondering that possibly that there's some increased intracranial pressure going on in this patient. Really, they say less than 5 millimeters rules out any elevated ICP in adults. Here's actually a good picture of a swollen optic disc along with a view of the optic sheath here. You can see that the optic sheath is again this hypoechoic region towards the posterior segment of the eye that's surrounded by kind of a more hyperechoic area of tissue. You want to measure the diameter using the calipers on the ultrasound machine. to see really how wide it is. Again, over 5 millimeters would indicate there may be some increased intracranial pressure, as well as a swollen optic disc that you can appreciate here on this picture. Is really kind of a bump out seen on the posterior segment of the eye, and that can indicate as well some intracranial pressure that's increased. So just some take-home points. Make sure that you cover the closed eye with that transparent adhesive. Tegaderm works beautifully. I know sometimes you may get a little freaked out that this Tegaderm may pull some eyebrow hair off or some eyelashes. It really doesn't. You don't have to worry about that. But make sure that you remove all the air from under the Tegaderm in order to decrease the chance that you'll have some real difficulty viewing your ultrasound screen because there's kind of air obstructing your view. Also, have that patient again move the eye back and forth with normal gain, and look for a flap that may be tethered to the back of the globe that may indicate either that posterior vitreous detachment or possible retinal tear. Really, the retinal detachment will have a thick flap that will be pretty easily visualized when you have the ultrasound on low gain. But if you really want to evaluate the entirety of that vitreous body, turn that gain up. It really helps out to be able to visualize any posterior vitreous detachment. So always turn that gain up and down when you're looking at the eye. And as well as increase the gain slowly as you're doing this, because it will really kind of help you evaluate the entirety of that retina and the vitreous body. Also, you want to make sure you scan in 2 planes, that sagittal plane and the transverse plane. It'll really allow you to get a nice overall picture of what's going on with the entirety of the eye. And compare it to the unaffected eye as well. If you think there may be some pathology going on in the eye that the patient has complaints about, always compare to a normal eye or the patient's other eye that he or she is not complaining about. And have them move in all directions, as I said before, so you can see all portions. And to hammer home this point again, too much or too little gain is really not possible with this. You want to make sure you cover a wide range of gain in order to make sure you're evaluating the entirety of the structures in both the anterior chamber and that posterior chamber. These are a list of my references for this podcast. Thanks for watching. Hopefully this podcast helps you feel more comfortable using ultrasound to evaluate eye pathology within the emergency department. Thanks again.